Yes, I'm on. Good morning or good
Okay.
evening, as it may be.
Yeah, good morning. All right, so thank you everyone for joining. And as you know, we have recently started the Nepal's first institutional poison center, and you can see the flyer here. We have been on for about 4 or 5 months, and it's been quite busy. We've been helping a lot of people calling about poisonings from Nepal. This is the phone number here, 01450 So if you haven't gotten a chance to save this number, or to share it with your friends. It's all free service at the Poison Center. And we are based at TUTH in Kathmandu. And we are partnered with Brown University, which is our institution here in the United States, where Dr. Bloom and I work at, as well as a nonprofit organization in Nepal called AS Foundation. So we thank all the partners for making this possible. And we do monthly webinars, and we try to bring topics that are interesting to you and from experts around the world. And you'll hear today about a topic that's really important in toxicology and something that hopefully will help you clinically as well. So without further ado, I'm going to introduce our speaker for today. Today's speaker is Dr. Joshua Bloom. Dr. Bloom is a colleague of mine, and he's an assistant professor of emergency medicine at Brown Emergency Medicine in Providence, Rhode Island. He not only has an MD, but he also has a PhD from Zucker School of Medicine, and he completed his medical toxicology fellowship at NYU after his residency. He has designed and implemented hybrid toxicology curriculum for diverse learners and has also led the New York City's Poison Center's effort to combat the rising morbidity and mortality from toxic nitrites. While at Brown here, he is responsible for toxicology education and is one of the leaders of toxicology in the department. His academic interest and active projects are on molecular toxicology, toxic nitrites, public health surveillance and intervention, social media, and intersection of toxicology with mental health. So we're going to open the floor now for Dr. Bloom to share his slide, and today's talk is going to focus on heavy metal toxicology. Thank you, Dr. Bloom, and the floor is all yours.
Thank you so much, Dr. Burrell, and I'm very grateful to have been invited. Let me work on sharing my screen.
I'm going to stop our sharing. There you go. And for just logistically, as Dr. Bloom is sharing his screen, everyone, please mute yourself. Having background noise is not that helpful. And then if you have any questions that arise during his presentation, please type on the chat. And then when you're done, I'm going to sort of direct those questions to Dr. Bloom. And then after Dr. Bloom, we have one more small presentation, which I'll introduce after Dr. Bloom's talk. So thank you.
There's some settings issue on my end, Dr. Carell. It might be that I have to sign out and come back in. Give me a moment.
Dr. Amu, you're in mute.
Oh, great. Thank you, Dr. Yeager. While Dr. Bloom is joining back on, I'll just introduce our team here briefly. So from the TUTH side, I see Dr. Rakesh Gimire. He's been the sort of partner in making this happen over the last year and a half. He's currently in New York, but he's here on Zoom. We have Dr. Rajesh Sharma, Dr. Ayushma Pandit, and Dr. Rishika Rishika here from our Poison Center Spies group, who are the people who are going to be answering your phone call in Turkey. And then we also have Dr. Yagya Timilson IC here, who is representing AS Foundation, and I see Anjana Thapa, who is our sort of coordinator and helps us through AS Foundation. So thank you everyone for joining, and looks like the presentation is on. So Dr. Bloom, it's you. Thank you.
All right, and can you hear me?
Yes.
Wonderful. All right, so again, I'm very grateful to have been invited. Again, my name is Dr. Bloom, and it's a pleasure to be speaking to all of you. And I thank you all as well for coming to attend at a time which it might be, I believe, a little inconvenient for you. So I very much appreciate that. Just some additional introduction to myself and my current practice. At the moment, I'm primarily an emergency physician, although I did train in medical toxicology, and I just finished my fellowship in medical toxicology in New York City. So my primary practice and training has been in American cities. So that means, you know, a diverse patient population, large volumes of patients, but also a large amount of access to resources. It's something you should keep in mind when I give this presentation, just because my own experience has been in this practice pattern. And I have found, especially when I speak internationally or when I speak to folks who practice internationally, our practice environment might be quite different, and our approaches might be quite different. And I would certainly appreciate any feedback or questions or alternate perspectives you could offer after my talk is done. And I'll have my contact information at the end of the talk as well. And I don't have any relevant financial disclosures. So this talk is about metals, and you know, I usually like to start by looking at the periodic table when I talk about metals. And you know, I'm sure a lot of you have seen this before. And you know, for your information, metals are on the left of the table. You know, and those are the ones that are marked in blue here. Most metals are solid. They have common properties like luster and malleability. They conduct heat and electricity. And in the context of toxicology, you'll often hear about heavy metals. And those are metals that have a high atomic mass. But light metals like lithium are often clinically significant. And so we'll be talking about both types of metals, but most of the metals we'll be talking about today are heavy metals. So what I'd like to do with metals, because the toxicities of metals are often diverse and very difficult to remember, I wanted to just put all of what I know about metals together on kind of one slide of general principles for you. And so let's just go over these. You know, metal ions often resemble native ions. So even if these metal ions don't have a role in the body, they could have a pathophysiologic effect based on their resemblance to native ions that the body does use. And that often drives the pathophysiology of a heavy metal. Now, heavy metals often have multiple redox states, you know, and that's especially true of the transition elements. And that means that there will be multiple forms of these metals that might have distinct toxicities. And those distinctions could be in regards to pharmacokinetics, in regards to immediate local versus systemic effects, and in regards to, you know, one redox state might be more toxic than the other. And those details are difficult to get into in the time span of this talk, but just be aware of that. Usually with metals, multiple organ systems are involved. And so that means that patients, especially with severe metal toxicity from a metal, I would expect there to be multiple systems, and you'd look for symptoms and signs from multiple systems. Diagnostics can help in metal toxicity, but my approach to toxicology in general is that symptoms are much more important than diagnostics, including blood concentrations. As well, diagnostic tests can be challenging to interpret. I will also say that there is a difference in metal toxicity diagnostics between, for example, a clinical setting where you have a single patient and you might have sent blood or tissue for concentrations, or perhaps a forensic setting where, you know, you might be examining a person after death for evidence of metal toxicity, and then an environmental setting where you might be looking at some environmental source for metal, and that area of testing is also completely different. Diagnostic testing in metals can be its own talk, and so I just wanted to let you know that those are complicated. Many metals are radio opaque, and that's part of the diagnostic approach to metal toxicities. However, you should be aware that not all metals are radio opaque. For example, lithium is not radio opaque. Usually in metal toxicity, we do not expect to be able to use activated charcoal, because many metals do not stick to activated charcoal, and therefore you cannot use activated charcoal to prevent absorption of the metal, usually. But you oftentimes can still use gastric lavage. You can use whole bowel irrigation, that's WBI, and sometimes dialysis is available for extracorporeal removal. Now, there are antidotes for multiple metal toxicities, and we often refer to these as chelators. So here are some examples of chelators. So chelators are often small molecules that can donate electrons to form complexes with positive metal ions.
15 मिनट वेस्ट करे सो वेबिनार को
Please mute yourself.
यो पोइज
Ashish and Ty, please mute yourself. Okay, go ahead. Sorry, Dr. Bloom.
Okay. All right. And obviously, if there's any questions, yeah, please put in the chat or raise your hand. I'll do my best to answer in real time. But yes, so DMSA is Suxmer. DPA and DMPS are other similar chelating agents. I don't see those in frequent use. I personally am not taking the approach of memorizing these because they don't come up very often in my clinical practice or in most of the practice of toxicologists that I know. But one thing I'd like you to think about when looking at these molecules is that they certainly wouldn't be specific, right? Because these are just negatively charged molecules. And so they would non-specifically bind to multiple metals. And that drives the toxicities associated with the chelators. And that's why chelator use should be considered carefully. I want to start talking about lithium, and I kind of organized this talk around potentially the periodic table, but we'll start with the lightest metal of significance first. So lithium is used clinically for bipolar disorder and major depressive disorder, so it's used in psychiatric patients. Pathophysiologically, it's important because it resembles sodium and therefore transports similarly to sodium. And also the treatment of lithium toxicity is directed at the fact that it will behave like sodium. Therapeutic concentrations of lithium are between 0.6 and 1.2 milliequivalents per liter. And lithium levels can be tracked to maintain therapeutic levels. Acute toxicity from, for example, a lithium overdose, I would expect to see, as you'll see in all of these metals, multiple systems involved. So immediate GI toxicity is expected, gastrointestinal toxicity, and that's including nausea, vomiting, and diarrhea. Most clinically significant is neurotoxicity, and these patients can develop an altered mental state. They can develop ataxia and tremors. And SILENT is an acronym for the Syndrome of Irreversible Lithium Effectuated Neurotoxicity. And this is I would say, not well-defined set of neurologic and neuropsychiatric symptoms that can afflict patients who have had lithium toxicity. And SILENT can be disabling and permanent. And that is one of the biggest concerns in lithium toxicity, that patients might develop this condition and then be stuck with chronic ataxia or cognitive deficits. Now, there are also acute on chronic toxicities, and that's often seen in patients who develop a kidney injury while taking lithium. So as they take their normal dose, their elimination is reduced, and they effectively dose stack. Patients who are chronically on lithium, tremor is often seen, about 27% of these patients. And nephrotoxicity can develop, including nephrogenic diabetes insipidus in patients, and they'll develop polyuria and polydipsia. And chronic kidney disease can develop in patients on lithium. Thyroid disorders are possible on lithium, and so thyroid function should be monitored over time. And cardiotoxicity is possible. There are EKG changes that you can see in patients with a lithium overdose or chronic lithium use, but these changes are hard to be specific. Sometimes QT change is seen, or other specific morphology changes on the EKG. Lithium can be teratogenic in pregnancy. The treatment for lithium toxicity, whether it's acute or acute on chronic, generally involves hydration with normal saline, and that promotes natriuresis and therefore also elimination of lithium. You can perform gastrointestinal decontamination with gastric lavage or whole bowel irrigation, depending on where you suspect an acute overdose bolus is sitting. And then hemodialysis is an option because lithium is very dialysable. Now, the picture on the left of the slide is the logo for XTRIP, and that's an international work group that develops consensus recommendations for extracorporeal treatment in poisoning. And extracorporeal treatment can include hemodialysis, hemoperfusion, plasma exchange. And lithium is one of the poisonings that this work group has developed consensus recommendations for. And I'm going to put the consensus recommendations about lithium poisoning here, just for you to look at quickly. You should know that the consensus here is a consensus of toxicologists and nephrologists internationally. And so there's been input from both of these specialties, and I generally use these consensus recommendations when I'm considering extracorporeal treatment or ECTR in any form of poisoning, as long as they have recommendations available. You can see that extracorporeal treatment is recommended in patients with severe lithium poisoning, and especially in patients with kidney impairment and a high level, or signs of end organ toxicity, such as dysrhythmia and altered mental state or seizures. Now, I usually like to reinforce my teaching with cases, so I'll just give you a sample case that I saw when I was practicing clinical toxicology. And so this was a case of a 42-year-old male who came into the emergency department with frequent falls. And they fell a few times in the week prior. They weren't sure why they were falling. They did carry their medications in a large bag around them. They weren't quite sure how to take them. This patient had a history of bipolar disorder. They were on medications like lithium carbonate and escitalopram. And this patient was carrying multiple bottles of every one of their medications. And it would seem that the patient would haphazardly be taking medications from various bottles multiple times a day because they weren't sure how to use them. This patient had ataxia on exam. They were unable to tandem gait, and they were occasionally tangential when they were speaking. They were only oriented to self and to place. So their diagnostics showed an abnormal creatinine, as well as a high lithium concentration. And so in this case, we started normal saline at twice maintenance to encourage natriuresis, and we applied the extra criteria which recommended hemodialysis in this patient. I will say that hemodialysis was done, however, it was initiated late in this case. And despite therapies, this patient had residual ataxia, even after their lithium toxicity otherwise had resolved. So their mental state cleared, but they had persistent ataxia. So I would say this person had developed silent, potentially subacute or chronic lithium toxicity sequela. This was another case of an 18-year-old female who likely had an intentional overdose. And this patient was found with evidence of emesis and pill bottles around her, had a history of bipolar disorder. And her home meds included extended release lithium carbonate. And this patient was disoriented, had concerns for not protecting her airway, and actually developed a tonic-clonic seizure while in the emergency department. Diagnostic-wise, she also had an abnormal creatinine, and she had a very high lithium blood concentration. So this patient had her airway protected by endotracheal intubation, and she received benzodiazepines for seizure treatment. She received whole bowel irrigation with polyethylene glycol electrolyte solution, and she had a nephrology consultation, which was helpful to initiate hemodialysis. And this patient survived. So let's move on to a different metal. And this is another metal that's used in pharmaceuticals. So iron is used for iron deficiency, as well as in prenatal vitamins. The physiology of iron is that it's involved in multiple oxidation and reduction reactions. It's also incorporated into hemoglobin, and it's relevant to multiple disease states. So the toxic dose of iron is generally considered to be greater than 20 milligrams per kilogram of elemental iron. And above greater than 60 milligrams per kilogram, I would expect very severe toxicity or even death. These amounts are important because iron exposure, at least in my practice area, is fairly common among the pediatric population. It's usually like prenatal vitamins where a newly pregnant mother has a young child in the house. And so the amount of ingestion is very important in considering the risk stratification in these patients. I have a chart here on the right side of the slide, and this is taken from Goldfrank's Toxicologic Emergencies, This just gives the percentage of elemental iron in various formulations because you can't use the milligrams of the tablet itself, since only a certain percentage of that is elemental iron, and that's the important part of the tablet for toxicity. Now, we should know that we don't directly excrete iron, and that's why, for example, patients who are transfusion dependent or have a long history of transfusions, such as patients with sickle cell anemia, develop iron overload and require iron removal by actually chelating agents. The phases of acute toxicity of iron, this is actually one of those toxicologic conditions where the toxidrome has multiple distinct phases and they're pretty easy to map. So initially, when a person takes an iron overdose, you expect GI symptoms. And this is important because there's essentially no such thing as an acute iron overdose with significant toxicity and no GI symptoms. These patients must have nausea, vomiting, or diarrhea because iron is extremely irritating to GI mucosa. And so this is one of the ways that we risk stratify patients as well. If you're concerned that a patient might have been exposed to iron, but they never developed GI symptoms, then they've essentially ruled themselves out. It is impossible to have iron toxicity except maybe IV iron, but it's impossible to have oral ingestion iron toxicity without GI symptoms. So between 6 to 24 hours, you often see what we call a latent phase. And multiple toxicologic conditions have a latent phase like acetaminophen or amanita mushroom toxicity, but these latent phases are not subtle. These patients may not be actively vomiting anymore, but they'll often look sick and they'll develop laboratory abnormalities like acidosis. And so they won't be completely well appearing. Patients with a consequential amount of iron on board will eventually go into shock after the latent period, and that's a mixed shock, and then liver failure. And that liver failure is treated like any other form of liver failure with the usual supportive measures that you would use. If the patient survives, the fifth stage of iron toxicity is that you'd expect them to develop a post-recovery gastric outlet obstruction, and that might require supportive measures or interventions later on. There are multiple diagnostics that we use in iron toxicity, and that includes abdominal x-rays because iron tablets are often radio opaque. We collect iron concentrations, and usually those peak at around 4 to 5 hours post-ingestion. And usually I expect significant toxicity to be correlated to an iron concentration of greater than 500 micrograms per deciliter or greater than 90 micromolar, micromoles per liter in SI units. I also expect these patients to develop a high anion gap metabolic acidosis. The treatment for iron toxicity is GI decontamination, aggressive supportive measures, including airway protection and supportive hemodynamics. And finally, there is a chelator available, deferoxamine. And again, like all chelators, deferoxamine carries its own toxicities. So here's some images that are helpful to view. On the left is a pediatric patient who had an iron and tablet ingestion. And the picture on the left shows the patient with the iron tablets, with visible iron tablets in their stomach by radiograph. And the picture in the middle is showing that same patient after a gastrotomy is performed to clear those iron tablets. But you'll note the arrow is pointing to the lungs now because this patient has developed signs of acute respiratory distress syndrome. The picture on the right is serial urine samples from a patient that was treated with deferoxamine. Now, when you treat patients with deferoxamine, it forms a complex with iron called ferrioxamine, which is a colored compound that's eliminated renally. And that's visible in the patient's urine. So usually I collect the baseline urine and then start deferoxamine in these patients. Now, deferoxamine's toxicities include hypotension, and that's often infusion rate dependent, as well as itself causing ARDS, which is unfortunate, especially since this patient population can get quite ill. Deferoxamine can't really be used for more than, I believe, 24 hours. And in any case, its highest utility is early on in an overdose because intracellular iron is less accessible for chelation. So a sample case, this is a young female who was found with blood-tinged emesis at home after ingesting pills from the medicine cabinet. This patient didn't offer any history, but the medication in the cabinet was ferrous sulfate, 325 milligram tablets. And this patient was found in distress with dry heaving, epigastric tenderness, and they had multiple abnormal diagnostics. You could see on their blood gas, they have acidemia with a pH of 7.29 and a PCO2 of 30. Their lactate was 3.0 millimole per liter. Their 4-hour iron concentration was 670 micrograms per deciliter, which equates to about 120 micromoles per liter. They didn't have acetaminophen or salicylates in their system. There were no evident tablets on an abdominal X-ray, so aggressive GI decontamination was not pursued.
तर केजी भनेको थियो 20 मिलिग्राम per kg भनेको थियो toxic dose.
Sorry, is there a question?
Please mute yourself, ma'am.
Okay.
Please type
And
your questions in the chat. Yeah, thank you, guys.
okay. And so this patient was admitted to the ICU, and they had baseline urine collected, and then they were started on deferoxamine, and they clinically improved. So this is a 15-month-old who presented with vomiting and a potential ingestion. And they were found by their mother with a half a pill of an iron tablet in their mouth. It's unclear how many this patient had gotten into because the bottle was left nearby and the patient only vomited once prior to arrival to the emergency department. And this is a fairly common presentation, at least in my practice area. You know, a single episode of vomiting without persistent GI symptoms. And this was a healthy, vaccinated child with a normal physical exam. Blood diagnostics were sent on this patient with a normal pH, a normal lactate, and a not concerning iron concentration. So this patient is always a question, right? Because this patient had an episode of emesis, and you could consider that they might be susceptible to toxicity. However, a half a pill of iron tablet, especially when calculated against the patient weight, was a low concern for toxic exposure. And so in this case, providers discussed safe medication storage with the parents, and then the patient was discharged home with a follow-up visit scheduled with their pediatrician. So let's move on to lead. Lead, unlike the other two metals that we've talked about so far, has absolutely no physiologic role. That means there's no normal level of lead in blood or tissues. And standards are often set by, you know, the locale in which you're in as to what is an acceptable amount of lead. And in the United States, the acceptable amount of blood lead level, BLL, has been going down persistently over the years. Initially, the acceptable blood lead level was around 25 or more. And then, you know, further research kept coming out that lower and lower concentrations of blood lead were associated with, you know, potentially permanent neurological and neurocognitive deficits. And so nowadays in the United States, an acceptable blood lead level is less than 3.5 micrograms per deciliter, which would translate in SI units to 0.17 millimoles per liter. Now, in the body, lead tends to follow the same transport and physiologic pathways as calcium and magnesium and zinc, and that drives its toxicities, which are again multi-system. So neurotoxicity is the most concerning thing for lead, and there's a wide range of toxic sequelae of lead. But these can include neurological deficits, altered mental state, seizures, and especially in low-level chronic exposure, you can see permanent neurocognitive deficits, and that can include developmental delay, difficulty meeting milestones, changes to IQ have been observed that are directly related to the level of blood lead concentrations. Hematologic toxicity is expected, all right? And so these patients will often have an iron deficiency anemia, especially in patients with chronic exposures to lead. And that's one of the hints when a patient has an incidental finding of an elevated blood lead level that their exposure could have been chronic. Nephrotoxicity is expected, and you can see acute kidney injury, AKI, or chronic kidney disease develop in chronic exposure, CKD. Saturnine gout is something that's a bit of a historical thing with lead. And lead, traditionally has a sweet taste in multiple of its compounds. And so especially in ancient times, lead compounds were used to sweeten food products. And so Saturnine gout would develop in folks who consumed these products, and was often considered a disease of the rich because folks who were rich were able to afford sweeteners like lead-containing compounds. Skeletal toxicity is also seen, and that primarily presents as growth impairment, but you can see evidence of lead toxicity as lead lines on a radiograph, and we'll have an example of that. The diagnostics that we use for lead toxicity are a blood lead level, BLL, and you can collect this as a capillary or a venous collection. The downsides of a capillary collection is that it requires rigorous cleaning of the site before capillary blood is obtained. And since it's highly superficial, there's a higher risk of contamination from skin surface contaminants. And this can really produce a lot of errors just because lead is present in the environment. The primary treatment for lead toxicity is to remove the exposure. And whether that's the pottery or ceramic that contains lead that's been used by the patient, or covering up lead paint that's coming from the walls, or removing access or ceasing use of a contaminated water source. And a patient with acute lead toxicity and evidence of a persistent gastrointestinal burden, I would do GI decontamination. You can't use charcoal in this case, but you can use lavage if there's a stomach burden, or whole bowel irrigation is more commonly used because these exposures are often chronic or subacute, and therefore the burden is often distributed in the intestines. Chelation is available, and British anti-lewisite, calcium disodium EDTA, and Succimer have all been used in the past. And generally, the usage is Succimer, an oral tablet for patients with mild lead toxicity, whereas British anti-lewisite, an intramuscular treatment, and calcium disodium EDTA, an intravenous treatment, is used in patients with severe lead toxicity. And Dr. Carell is remarking that lead in turmeric, because of polishing, is still an issue in the region, and that's definitely also been reported in the United States. So spices have also been reported as a source of lead. So here are some useful images for you to see regarding lead patients. So the images on the top are both skeletal radiographs. And you can see lead lines here, which is increased metaphyseal density. And those lead lines that you're seeing at the metaphysis are actually not made of lead. That's caused by abnormal calcium deposition because bone calcium metabolism is dysfunctional in the presence of lead toxicity. The bottom left photo is an image of a peripheral blood smear. And you can see what we call basophilic stippling of erythrocytes. And this is caused by a deficiency in RNA degradation. Those basophilic stipples are clumps of RNA. And that's because lead directly inhibits the enzyme that's responsible for RNA degradation in erythrocytes. On the bottom right, you can see, again, a child who's been exposed to lead and has a persistent gastrointestinal lead burden. And that's the small flecks you're seeing in this abdominal radiograph. This child had pica and presented with significant lead toxicity. They received gastrointestinal decontamination with whole bowel irrigation, and the radiograph on the right is after decontamination is done. You can see that those flecks of radiopaque material have disappeared. But if you look closely, you'll notice that in the bilateral femur, there's still evidence of lead lines. So this child had a chronic exposure to lead. So we'll talk about a case. So this is a 12-year-old female who presented with abnormal laboratory tests. Their pediatrician had obtained a blood lead level of 60 micrograms per deciliter, which is equivalent to 2.9 micromoles per liter. And that was drawn 2 days prior. Even in the United States, blood lead levels are oftentimes not easily available. And this patient presented with chronic bilateral knee pain and chronic headaches, and they had a history of anemia of unclear etiology and were taking supplemental iron. I'll pause just to agree with the comment that was made in the chat about Ayurvedic medicines, because yes, these do often also contain lead. Especially if you have a patient who has concern for lead toxicity, one of the most important things is to identify the source, asking about exposures like spices, Ayurvedic medicines, use of old potteries, presence of lead paint in the home. These can all be common sources of lead. So this patient had a normal neurologic exam. They did have a low hemoglobin, as well as a low MCV. So they did not have basophilic stippling on their blood smear, nor did they have foreign bodies on their X-ray of the abdomen, or lead lines on the radiographs of the knees. So this patient had pica, and they had an exposure to lead in the house that was removed. They received DMSA, Succimer, because their toxicity was mild. And other children in the home also had testing done for lead. And this is another thing to consider, especially, because these, a lot of families have multiple children. And if there's an exposure to one child, there's often an exposure to multiple children. So one of the standards of care for lead treatment is to evaluate the other members of the home to determine if they have lead toxicity, and especially children, because children can be prone to pica. So this is another case, and this is a bit more severe. This was a 6-year-old who presented with an altered mental state. And this child was known to have pica and was known to have elevated blood lead levels, which was likely due to old paint in their home. And so they were found with convulsions, and they arrived to their emergency department obtunded with pale conjunctiva. They had lead lines on gums, so actually their mouth had mucosal changes consistent with lead, and they kept having recurrent convulsions. So their blood lead level was not available at the time of their presentation, but in retrospect resulted extremely high. They did have basophilic stippling on their blood smear, and their urinalysis showed evidence of proteinuria, which was suggestive of kidney dysfunction. Their abdominal X-ray had innumerable radiopaque foreign bodies, as well as evidence of lead lines. So this patient had to receive aggressive supportive care, and they had their airway protected. They received benzodiazepines as well as intracranial pressure management because cerebral edema is often seen in patients who have lead encephalopathy. They received IV fluid support. They received whole bowel irrigation to remove their gastrointestinal burden. And they also got chelation with British anti-lewisite and calcium disodium EDTA. Again, just like mild lead cases, the exposure was removed or remediated, and other children in their home were evaluated. So I'm next going to go into some what I would consider more esoteric metals, and I'm going to go more briefly into these types of cases. And that's because I haven't seen a case of, 2 out of 3 of these because they're fairly rare. But their toxidrome is interesting and they're historically significant. So arsenic, all right, arsenic exposures traditionally come from contaminated well water. or metallurgic or chemical occupations, but it's also been found in pressure-treated wood, as well as some chicken feeds. So acute arsenic exposure, you expect to see GI symptoms, and that includes rice water diarrhea, can resemble cholera. Eventually, you would expect to see cardiotoxicity, and these patients can also develop what appears to be a systemic inflammatory response syndrome. They could resemble sepsis, and they eventually will develop multi-system organ failure, shock, and the death is often due to a cardiac cause. Now, chronic toxicity or late presenting arsenic toxicity in a survivor, you can see evidence of a painful peripheral neuropathy or an ascending weakness that resembles Guillain-Barré syndrome, but without diagnostics consistent with that diagnosis. You can also see evidence of arsenical dermatitis, and patients with chronic long-term arsenic exposures are at risk for malignancy, especially of the skin, the lung, and the bladder, as well as cardiovascular disease and chronic respiratory disease. Now, the picture in the middle here of the slide is an example of arsenical dermatitis. The pictures on the left and right are mnemonics. The left shows a summary of the aspects of arsenic toxicity, and the right is an old advertisement, actually, because arsenic used to be incorporated into treatments to improve people's complexion, because our chronic arsenic exposure would tend to cause an anemia and pallor. The treatment for arsenic exposure is GI decontamination, and actually activated charcoal does appear to stick to arsenic compounds. Chelation is available, and you can use British anti-lewisite or DMPS or Suxamer. Here's a sample case. This is a 65-year-old with bilateral leg pain that had been worsening for weeks to the point where they weren't able to walk anymore due to pain in their soles. And they also have intermittent nausea and vomiting. This patient had demonstrable weakness to the lower extremities and was unable to bear weight. They had hyporeflexia and severe hyperesthesia. This person had a normal lumbar puncture, was evaluated for Guillain-Barré syndrome, but didn't seem to be diagnostically consistent with that except for the clinical presentation. So in this case, my approach would be to admit them to the hospital for supports. The diagnostics would be a 24-hour urine arsenic test. And if that was positive, I would consider chelation. And obviously, you have to work up other causes, primarily Guillain-Barré syndrome in this kind of case. This patient, you know, in this simulated case, had a malicious exposure, and you know, arsenic is traditionally been used in the past by famous poisoners and maliciously, and so law enforcement would be activated if there was a concern for malicious exposure to arsenic. So let's talk about mercury next. And mercury is interesting because it's available and prevalent in multiple forms. And that includes elemental mercury, which is, you know, your classic liquid quicksilver, as well as inorganic mercury and organic mercury. Now, each of these, the exposure, you would come to it differently. And there's different types of concerning exposure depending on the form of mercury. For example, elemental mercury, you know, bad exposures are often inhalational, and you'd think of these in people who work in industry or mining, or who might have a close exposure to inhaled mercury, because ingestion of quicksilver, of elemental mercury, is often benign because it's not absorbed. You also can see people who inject elemental mercury intravenously, and that can produce multiple bad effects. Inorganic mercury is present in the chemical industry. It's also been used historically in drug and skin formulations or skin lightening creams. Patients who ingest inorganic mercury are expected to suffer a hemorrhagic gastritis and can develop shock and acute tubular necrosis of the kidneys. organic mercury, oftentimes you expect this exposure from contaminated well water or contaminated fish, but you can also see it from wood preservatives. These patients might develop vague GI symptoms and then eventually suffer neurologic sequelae after long-term exposure. And very bad fetal teratogenic effects have been observed. And you can see the picture on the bottom left here is an infamous photograph, actually, of a patient with Minamata disease, which was a result of contamination of the water of Minamata Bay in Japan with methyl mercury and organic mercury. And that caused widespread neurologic sequelae of the local population who was reliant on those fish for food, as well as teratogenic effects in their children. So the diagnostics for mercury is usually a whole blood mercury concentration or a 24-hour urine. The treatment for mercury exposure will again depend on the type of exposure that was had. You know, inhalational mercury can't decontaminate usually versus a gastrointestinal burden can potentially be decontaminated. There are chelations available depending on the type of mercury exposure that occurred. And I have this table on the top left here that summarizes both the symptoms you'd expect to see as well as the available treatments. You know, British anti-leucite and succimer for elemental and inorganic mercury exposures. And for organic mercury exposure, early in the exposure, succimer is considered. But for patients with long-term exposure to organic mercury, I don't expect chelation to be effective. I want to go over the photos here because they are helpful and interesting. The top photo is chest radiographs of a patient who attempted an intravenous injection of elemental mercury. This caused an embolism, and you can see that the elemental mercury distributed among their pulmonary vasculature, as well as in multiple other areas. The picture on the right is another patient who attempted an intravenous injection of elemental mercury. And in this case, the injection extravasated and caused local necrosis. And you can see internally on the radiograph that there's still mercury present in the subcutaneous tissues. And finally, the picture in the center of the slide, I want you to look closely. These are two cerebella. The left is from a patient who was exposed to around a single drop of dimethyl mercury. And this was a scientist who was working with the compound for research. So the right cerebellum is normal. The patient who had this exposure experienced a very long and unpleasant neurologic course from which, you know, they were essentially had irreversible neurologic damage and irreversible decompensation and death over a period of months. And so dimethyl mercury is a highly toxic compound. And you can see on this section that patient's cerebellum had evidence of diffuse atrophy. So here's a patient that we saw in our clinic after mercury exposure. And they were actually sent in for urinary symptoms, but they were also being followed by a nephrologist for an unclear etiology chronic kidney disease. And abnormal heavy metal testing had shown an elevated urine mercury. And this patient had evidence of extremity and facial edema consistent with nephrotic syndrome. So this patient had 24-hour urine testing done, which confirmed the exposure, and they received chelation. In this case, the patient's exposure was due to skin lightening creams, which often contain mercurials. So finally, I want to talk briefly about thallium. And thallium exposure is vanishingly rare worldwide, as far as I know. You know, prior use of thallium included rodenticides, as well as depilatory preparations. So, you know, preparation creams to remove hair. And so thallium resembles potassium. And that's that contributes to its pathophysiology. It has multi-system effects and can cause multi-system organ failure, as well as dysfunctions of potassium physiology, which you can imagine could be quite disastrous. So patients with an acute exposure to thallium are expected to have abdominal pain and constipation over a period of days. And then if exposure continues, you might expect painful ascending paresthesias, neurodeficits, and coma to develop over weeks. And these patients can also develop a classic alopecia, which is pictured on the left here. Now, these patients can often die within weeks, and the death is of multi-system organ failure or a sudden cardiac death. Patients who survive will often have permanent skin, neurologic, kidney deficits. And just an example of the kind of skin findings you can see, here are some Mies lines on the nails of patients who had thallium exposures. The diagnosis is done from a 24-hour urine. Again, this is a very rare exposure, what I would expect to see perhaps in a person using an old rodenticide or in a malicious exposure, a poisoning. And famous poisoners have also made use of thallium in the past to poison their victims. Again, charcoal can work for thallium exposure, and Prussian blue is the antidote. This is another type of GI decontamination measure. And some studies have looked at using charcoal and Prussian blue together or in concert. Hemodialysis and hemoperfusion are possible treatments in patients with this, but oftentimes these patients will expire despite supportive care. One thing to note is that potassium administration can be painful for these patients because it can drive acute toxicity and severely worsen painful paresthesias. So that's another complicating issue in these patients. So this is a sample case of a person with, chronic indolent abdominal symptoms, worsening body aches, hair loss, the classic toxidrome, as well as multiple exposures in the same place of work. And this is the kind of situation that's been observed in persons who attempted to poison their coworkers with thallium. Multiple vague GI symptoms, multiple presentations to emergency care, and the diagnosis often missed, even though all of the patients developed classic hair loss. Diagnostics are frequently not available for thallium, but you can do 24-hour urine testing again. And even if you give activated charcoal and Prussian blue, these patients often will die despite treatment. So that's everything I have. And I think we're in a decent amount of time. I hope I don't go too far into the next section, but I'm happy to take any questions. And again, I want to thank you for inviting me to speak to you today.
Thank you, Dr. Bloom. This was a fantastic lecture, really comprehensive, really useful. Does anyone? We are kind of running short on time. We have maybe time for one or two questions. Does anyone have any questions for Dr. Bloom right now? If not, Dr. Bloom, what we'll also be doing is our SPIGE will reach out to all participants, and they will usually ask questions on emails, and we'll send that to you for answers, if that's okay.
That's perfectly fine.
One thing about Nepal is, there have been reports of sort of all this heavy metals finding in plants, and it's a high agricultural community, in farmers and things like that. So I think there's a big public health push that needs to happen, especially when it comes to things like lead. Lead is probably, we still don't know. It's probably really high amongst children. And as you were talking, I was thinking, man, I might have lead in my bones, deposit from my childhood. And that's a very common thing. So I think there's a lot of public health sort of interventions that still need to happen in the country. So, if I know you're interested in public health, if you're ever interested in doing some work around lead or other heavy metals, please, you're always welcome to join us. But without further ado, I will go ahead. There is one question. So here, Dr. Vikas says, what analytical technique is used to do quantitative determination of heavy metal poison?
Okay.
And another question, I'll tell you two questions. Another question here is there any clinical difference in nail finding in lead toxicity and thallium toxicity? They look similar to me.
Yes. So for the first question about analytical techniques, I would actually have to look up the principle of the assays used, so I can get back to you with that answer. But the tissue matrix that's used for analytical determination is often blood and urine in an acutely toxic patient. And you can consider tissue sampling and hair in a chronic exposure to potentially investigate prior exposures to heavy metals. There are caveats with an analysis of hair, as I'm sure if you're in forensic to toxicology, you might be aware. Just because since these heavy metals are prevalent in the environment, the sample needs to be carefully secured and cleaned. Controls have to be taken, and it's very challenging to interpret this. Post-mortem, it's actually interesting. Many heavy metals persist for very, very long time in human remains, and so if there's any suspicion of heavy metal poisoning in a person, potentially malicious exposure, this can be examined long after death. Then in terms of the question of the difference in nail findings, no, I don't think that there is a visible difference. These lines are quite non-specific. They're found in multiple types of metal toxicities.
All right. Thank you, Dr. Bloom. I think that's the only time we have for questions. So up next, for the next 10 minutes or so, we have one of our specialists in poison information, Dr. Ayushma Pandit, who will be giving us an update on the Poison Center and the work that the Poison Center has been doing over the last number of months. Yeah, some updates on that. So please welcome Dr. Ayushma Pandit. Please go ahead, Dr. Pandit.
Good evening, everyone. Is the presentation visible and am I audible?
Yes, you are.
Okay. Is the presentation?
Yes, we can see it and we can hear you. Ayushma, are you there? Lost her.
Okay, apologies for the power cutoff. We're having some serious power cutoff here. Okay, starting the presentation. Good evening, everyone. I am Dr. Ayushma Pandit, and I'm one of the spies currently working at Poison Information Center here in Nepal. Today, okay, am I not audible?
No, you're audible now.
No.
Please go ahead.
Oh, okay. I just saw the message that I was not audible. Okay, I'll just quickly start again. Sorry, everyone. Good evening. I'm Dr. Ayushma Pandit, and I am one of the spies working here at Poison Information Center in Nepal. Today, I'll be presenting the updates on the cases we have received till date. Before moving on to the statistical data presentation, I'd like to discuss in brief regarding how our PIC works. Okay, just give me a second. My presentation is not working. Okay, I am having some power cutoffs here, so okay.
Rajesh, are you able to share her presentation?
Just give me a minute.
Ayushma, Rajesh is going to share her presentation, okay? And you can talk, and he'll scroll through.
Okay, that'd be great.
Just one more minute. Let me load it.
If you guys have not saved the phone number of the Poison Center, it's 01450-2011. Ekdam sajilo cha hai. and it's 24/7. They're available. And we have international experts like Dr. Bloom who are helping us answer some questions we're not able to. So please save that number.
Can we move on to the other slide, Rajesh? Okay,
Can you all see my present screen?
yes, we can see your presentation.
Please.
Can we move on to the next slide? Yeah, okay.
Rajesh, we can only see we don't see the slideshow version. We only see and it's
Okay,
not.
so
Ayushma, if you're not able to share your presentation, maybe you can just sort of summarize without the slides.
yeah, okay, I think like that would be great. So
We're
I'll
running short
just
of
talk
time.
in brief about the framework on how PIC functions. Usually spies receive the call, and they are the initial ones who take up the call and provide expert consultation using resources like Talkspace and PIC protocols. We also have national and international faculties who provide their expert opinion when required, and the recommendation is then provided to the healthcare provider. Also, I would like to mention that the final decision about the patient care is provided by the healthcare provider and not PIC. So, like PIC is for the recommendation and providing expert opinion on the cases of poisoning and overdose. So we also follow up the patient accordingly. There is okay, there actually was a slide that showed the geographical distribution of calls from Nepal, and I think we are happy to say that we have been receiving calls from all parts of the Nepal. Also, till date, we have received 80 cases, and the bulk of which is formed by insecticides and pesticides, which constitute 38 cases, followed by analgesic antipyretic overdose, which constituted 9 cases, and other cases such as chemical exposure, household products have also made up the chunk of the calls that we are getting. So why get into the boring aspect of data? Because as junior doctors, we
Ayushma,
can
by the way, the slide
encounter
is visible.
such cases during our day-to-day practice. Oh yeah, okay, thank you so much. And during day-to-day practice, we can encounter such cases. So these data definitely help us getting prepared to see such cases. Can you please move on to the next slide, please? Okay, never mind. Out of 80 cases, 47 were female and 33 were the male cases that we had received. And this is the slide that represents the burden of cases I just talked about, 47.5 percentage of which is constituted by pesticides and insecticides, among which we had received 12 cases of organophosphate poisoning, and we also have seen a lot of cases of synthetic pyrethroids such as cypermethrin and deltamethrin cases as well. We have received around 8 cases of zinc phosphide poisoning and 3 cases of aluminum phosphide poisoning. And very strangely, we have received 1 case of superwarfarin as well, which has been used as rodenticide. We have also seen a significant number of herbicide cases constituting glyphosate and paraquat as well. Okay, let's go on to the next slide, please. This is just a graphical representation of the data I just mentioned. Also, yeah, let's go to, okay. Thank you so much, Rajesh. This is the number of cases that we have received. The most of the cases are from TUTH emergency department, and a few and many of the cases are from private hospitals all across Nepal. We have also received a significant number of cases from district hospitals and tertiary hospitals, but we have received a very few calls from health posts and community itself. The cases that we have received from are usually from adult emergency department, constituting around 66 among the 80 cases that we have received till date. We also have received around 6 cases from pediatric emergency department and adult ICU, and also 1 case from pediatric ICU. Let's move on to the next slide, please. Okay, this was the final outcome, among which 76 cases had healthy recovery, and there were 4 mortalities owing to aluminum phosphide causing 2 deaths, paraquat and multi-drug poisoning causing a single number of mortality cases. So I would like to conclude my presentation here stating that Poison Information Center is still an emerging concept here in Nepal, and it definitely is a significant milestone in the advancement of medical toxicology in Nepal. Let us all be part of this journey and help us help you. Do call us for any poisoning or overdose cases in the number 01450-2011. We're available 24/7. Thank you so much.
Thank you, Dr. Ayushma. That was great. Sorry about the technical difficulties there. Great work. Thanks to both our speakers today, Dr. Joshua Bloom and Dr. Ayushma Pandit. Now, do you guys have any questions? So I can see some questions here. So if one, can I ask everyone to show their camera so we can take a photo? And then 2, let's answer some of these questions. So one is IOM PIC planning to extend its service to peripheral hospital? Maybe Dr. Rakesh, you can answer this, but this is a service that's on the phone, and right now we're piloting it. This is a pilot study to see if this work is feasible in the country. And if this works out at TUTH, the plan is to have multiple centers in the future in different places. But right now, any hospitals or any people from all across Nepal can call this number, right? So it's not really limited to Kathmandu or TUTH or Bagmati region. So it's right now also available. Next, Dr. Rakesh, is there anything more you want to add to that?
Yeah, that's it. Thank you, Dr. Ram. That's it.
Okay. The next question we have here, so we'll just take like 3-4 questions and then we'll go for photos. Can you please let us know how information help in clinical cases? So Dr. Bikash asked this question. Knowledge is power, right? Like, so, we don't have the sad thing about Nepal is we have a large burden of poisoning. Our global burden of disease estimates nearly 2%, but that's probably underestimation. We have 0 medical toxicologists in the country. Now, that doesn't mean there are doctors who know toxicology in the country. They have done it for a long time, but we don't have a standardized protocol. We don't have a formal sort of training for it, formal capacity building. And so that's what we're trying to do with this poison center is, one, we're trying to provide information to clinicians, like the presentation that Dr. Bloom presented today, as well as build capacity of people like yourselves by offering educational seminars like this. So there's a sort of multi-pronged approach to that. And then finally, last question we'll take, is there any dedicated poisoning treatment center in Nepal too? So the poison center spectrum can go up to a poison treatment center, but we're starting with a poison information center now as we're piloting. But eventually in the country we do need, I think, a dedicated poison treatment center. But that's a little bit far ahead. As of current, we don't have any. All right, thank you everyone. Why don't everyone show your photo if you can, or show your pictures, and then we'll take a quick group photo with our speakers today. And then remember, we have social media that our spies and Anjana, who's here, they keep on posting about new seminars, new educational sources. So please make sure you follow those on Instagram, Facebook, and whatnot, Twitter, all those things. All right, I think everyone is showing that. Ayushma, show your picture. You're a speaker. We need the speaker's picture up in front. Okay, all right. Oh, and we also have a feedback form that will email you. Please give us feedback because it helps us make this better for you in the future. All right, everyone say cheese in 3. 1, 2, 3. Cheese. Okay, got it. Okay, I got one more.
Feedback form over here on the chat.
Oh, okay, great. Thank you. One more for the second screen. Cheese. All right. Got it. Okay. Perfect. Thank you, guys. Anjana just put a feedback form here. If you don't mind, it takes only like 1 minute to fill that out, and it helps us make this better for you next time. And I think that concludes our session today. So thank you so much.